Bismillah ar-Rahman ar-Rahim. Now, my dear house officers and medical officers and RMOs and PGs and those who are appearing in membership examinations or in the fellowship examinations. Now, I am talking on behalf of our channel which I have created, that is for the house officer and the medical officers at the practical side, to help them how to deal clinically the case which you will face in the emergency or in the wards. Now, this is the aim. So, our case presentation for the house officers case discussion sessions. It will be continuous discussions, and try to remember it, that just think about it that you are in the world. Imagination. This is an imaginary type of a discussion. In the wards, the case is admitted. This is the bed number 1. This is case number 1. And I am Professor Ali Haider. I am a global honorary professor of medicine without any fame or without any economics involved. Nobody is actually supporting me in these preparations. So the case number 1. Let's discuss this case. A 30-year-old working is a worker of a sanitary department, sanitary work, experienced nausea and distaste to the cigarette since 3 days. And then he noticed the dull type of the pain in the right hypochondrium, and because him specifically speaking, when he deeply inspired, or he bends forwards. And he also noticed the high color urine. The color of the urine became high colored. It may be orange colored, it may be the mustard oil colored, it may be possibility. But he said that the color is changed to very, very yellow. Then he started central vomiting, because it's not associated with the nausea, and it is the direct vomiting that is called central vomiting. And the patient is not responded with domperidone, which we are using in the ward as motilium. So you have to give some other preparations, like, for example, dimenhydrinate injections, possibility of it, or metoclopramide for the control of the vomiting. Now, he also noticed 101 degree Fahrenheit temperature, sometimes with the chills, and this type of the temperature is continuous in nature. Now, he also noticed the severe itching in the whole body after this event of about 7 days or 8 days. And what happened? That he was admitted in the A&E in severe drowsy state when he escaped from the car accident. He was very drowsy when he was driving, and that's why he escaped from the accident, because he stopped the car on one side and he became very, very drowsy, and the ambulance took him to the emergency department, where the case was seen by the CMO, and he ordered to admit in the medical ward, and he was admitted in the bed number 1 in the ward. In the ward, the history was taken as I have taken. Rather, you can take the history very well, because the provisional data will be provided. Then you see that is the presenting complaints with duration. The heart issues will be first, and then the lower pain, etc., etc., next. Then the history of the presenting illness in the detail, and it should be in the reverse order. The first which is appeared as a symptom or sign will be discussed first, and then second paragraph, and the third paragraph, and the fourth paragraph. You will write in paragraph wise, and the past history should be taken properly. Family history taken should be properly. If the attendant is nearby, he helps you to take the history properly. The other families or the members are affected for the same type of problems or not. For example, that is what's so important it is. For the past history is concerned, and personal history, and then the socio-economic history should be taken. And then we start the examination, the general physical examination, systemic examination, and then systemic examination, and then after the total examination, the presumptive diagnosis should be made. Remember always, the sequence is that after taking the history, you should detect the soft data and the hard data, and on the basis of the soft and the hard data, you should have some idea about the differential diagnosis of this case. Why he becomes drowsy, and what happened before this event. And then there may be differential diagnosis of 5 or 6 or 7, it is possible. Then the physical examination will taper this differential diagnosis. General examination revealed in this patient the temperature is 102 degrees Fahrenheit. They have pulse is 108 per minute. It is coinciding with the temperature, yes. It is not related bradycardia. The blood pressure is 100 by 70, slightly lower down, and dehydration is definitely positive, severely dehydrated patient. I am expecting the blood pressure lower than that. And yellow discoloration of the sclera were demonstrated. Now, look that this discoloration should be seen in the sunlight or the light which you use, the tube light or LCD light, not for the torch. Torch examination can become a false examination. Palms should be checked for discoloration. The other part of the body can be checked for the discoloration. And you will see that the yellowish type of discolorations are seen in the whole body. In this case, which I am dealing with this case. The liver is 2 centimeters, is palpable with tenderness, and it is the enlarged liver, because normally it is about, in our country, it is 9.5 to 11.5, but here it is more than that. It's 14 centimeters, and it's tender in the right hypochondrium. And there are scratch marks on the limbs and the torso, and the trunk, that is thorax, abdomen, scratch marks. And at this time when I was taking history and the physical examination, the Glasgow Coma scale was 11 by 15. It lowered down, that's why he is drowsy. Remember, the repeated vomiting can cause the problems, the hyponatremia and hypokalemia, and these are the problems of the disturbance of the conscious level. It was possible like this. Remember, on the, as a parking you can place in your mind. There is possibility. Now, investigations which were ordered and received urgently was blood CBC showing the hemoglobin 14 gram and RBC 4.3 million, hematocrit 41%. No problem in the RBC indices. The total leukocyte count is 3,800. It is lowered down. It is mild leukopenia. Among it, the differential is concerned. The neutrophil is 37%. It's lower down. It is normally 40 to 70%. The lymphocytes slightly increased because normally it is 20 to 40%. It is 54%. Eosinophils 6%. It is on the higher side, but it is normal. Basophils 3%. Slightly lower down, but it is 3 to 10% or 3 to 8% from labs. But it is not significant. Platelet is 1,10,000. Normally it is 150,000 in most of the people. But it is lower down. It is mild thrombocytopenia. And ESR was noted 32 millimeter per first hour, slightly increased ESR. So acute phase reactant 1 is higher in this case than ESR. Because this TLC which is lower down, platelet is also a marker of this activity. Acute phase reactant it is lower down rather, but ESR is higher. In spite of the normal hemoglobin. Now, investigation done on the next day, you can see at the time of the admission, these were the investigations. But afterwards, you have done investigation, and I have done, or you have done investigation properly, because I need the random blood sugar, which was 144 milligram. Definitely, it is the high one. No, it is normal one. That usually the random blood sugar which we took is less than 180 milligram, 120 to 180 milligram. Because random blood sugar is actually a misnomer. It is very much because of the different metabolic processes reacting together, and they rise the random blood sugar. The fasting blood sugar is the main examination. You want to diagnose hypoglycemia or hyperglycemia. So random blood sugar is okay, fine. The blood urea is 65. Normally it is 40. It is slightly higher. Serum creatinine is 1.7. It is slightly higher, not much. So I divide the ratio. For the ratio, I have to divide it. Divide 1.7 to 65. If it is more than 1:40, then it means that it is pre-renal type of a problem. It is not a renal problem. If it is less than 1:40, it means that it is a renal compromisation. The sodium, I already said that I was expecting it should be low because of the repeated vomiting. It is 130 milligram. Potassium is 3.4. It's slightly lower down. Chloride is 90, is lower down. Bicarbonate is 24. 24 means that it is 22 to 28 is normal. Although, because the potassium is not much lower down, if it is hypokalemia of 3, like 3.2, the hypokalemia is usually associated with the alkalosis, and bicarbonate will rise. So it is the inversely proportional with the potassium levels. It means that it is the dehydration which causes this. The PO2 ABG was ordered because patient seems to be in a respiratory distress type of a problem. Because the respiratory rate at the time of my first examination was 28 per minute. So PO2 was 65%. It is lower down. PCO2 is 38%. 38% means that it is normal, because we took about 30 to 45 is normal. The pH 7.31. 7.31 means slightly it is higher side, in alkalotic side. Because hydrochloric acid is removed with the potassium and the sodium, that's why I ordered the ABG to see completely that its pH is absolutely normal or not. Slightly higher means that it is alkalosis. Urine RV shows the specificity of 0.122. Is normal, although, but usually in a normal person who is taking water properly, it is about, you can say, 0.009 to 0.110 usually. The pH of the urine is 7.21. So it is slightly, you can say, acidic type of a urine, which is normal one. We will not significant. Glucose is negative. Proteins are traces. Because of probably the high grade fever can cause the benign proteinuria, and because it's not significant one. Blood was negative. Bile pigment was positive. Urobilinogen was positive. Bile pigment, that means that it is the bilirubin. You remember, it is the bilirubin which is in the liver, is conjugated, and it is excreted in the urine. That is the bile pigment. Urobilinogen are those urobilinogen that the bile is excreted and it is then again recycled out and it is excreted in the urine. So it is plus, means much urobilinogen is there. Means there is a much higher, I am expecting higher, total bilirubin in this case. The RBC on the macroscopic examination was nil, WBC nil, casts are hyaline casts are seen. Because this case is a prerenal type of azotemia. And hyaline casts are seen in prerenal azotemia. So my diagnosis was correct. Previously I have said that possibility of the prerenal type of a problem because of the dehydration. Look how we are calculating one by one, and analysis, look the analysis, part by part, everything in front of you. Urate crystals are positive. It means nothing in this patient, although. If there was a previous complaint of this urolithiasis, that is important. The liver is actually functioning. It means that liver is functioning, but it is forming urate, and that is why urate is formed. Otherwise, it cannot be. Some part of the liver, they are functioning. It indicates that. And then LFT was, total bilirubin was 7.8, is much higher. Indirect is 3.8, so I minus it. So it is 4.2 or something like this. So it is predominant conjugated hyperbilirubinemia. And clinically, if you classify this type of a jaundice, it is a jaundice patient. So it means that it is what is called hepatocellular type of jaundice, because indirect is also increased. ALT is 1890, much higher. Maximum it is 50, around 55, not more than that. AST is 1200. Again, the AST is about 45. It is 1200. Gamma GT 654. Gamma GT again it is about 55 to 60. It is much higher, much higher. The total protein was 7 gram. It is normally 7.5 to 8.5, slightly lower down. Albumin is 4 gram, 3.5 to 4.5 gram is normal. It means the albumin is not decreased. Remember, if albumin is decreased, or it is the albumin globulin ratio is disturbed, meaning that it is the chronic progressive liver disease. It's a marker of the chronic progressive liver disease. The PTINR, now this is one of the most important examination for any type of the acute type of event in the liver is concerned. PTINR is 1.9. Normally it should be less than 1, but it means that patient at risk now, higher risk of many things. It is 1.9 higher. So it means that the extrinsic pathway is much disturbed. APTT was not done in this examination, although you can order it and you can see the intrinsic pathway as well. But no need, it's not needed now, because the patient, I'm not diagnosing this patient as DIC still. The ultrasound abdomen showed enlarged liver with diffuse symmetrical type of echo texture. It is inflamed liver. If the inflammation is acute, this shows like this. Although the spleen is not enlarged in this case, but otherwise expecting spleen is also enlarged, but it is not enlarged. Fine. The X-ray chest was normal. It is a routine examination. You have to do it in any case. If there is any chances of you see that is the involvement of the cardiovascular system, then you have to do the electrocardiogram also. And some specific investigations were ordered on the second day. But serum ammonia is 52 micro per deciliter. It is higher. It means that the liver is damaged very badly, and the nitrogenous substances, they are not detoxified. As I have said in my previous videos about hepatic encephalopathy, that the nitrogenous toxins or nitrous toxins are the main problems which are crossing the blood-brain barrier and affecting on the brain. One is ammonia. It is not necessary. It may be mercaptan. It may be the other substances like benzodiazepine-like substances. Possibility of these type of substances are there, and other also not what is called hepatotoxins, which are not detected by the lab in Pakistan usually. We usually do the serum ammonia levels. It is raised. Simple as this. The hemoglobin surface antigen in hepatitis B surface antigen was negative. Hepatitis B antigen was negative. The anti-HCV was negative. Hepatitis BE, what is hepatitis B? It is active. It shows the active, because if the patient is in the phase what is called as the window period, the surface antigen will not be present. You have to do the anti-HBC or HBE to see that whether the patient is actually involving with the B or not. Anti-HCV antibodies was negative. Hepatitis A antibodies was negative. Hepatitis D antibodies, IgG, IgM negative. it means that one is not done. It should not be done because it is the remaining thing is hepatitis E, and hepatitis E is maybe the problem underlying, most probably. You can do the examination because it is the cost effectiveness of the investigation. That's why I do not order hepatitis E antibodies for IgG or IgM. Because the patient is young, possibility of the liver involvement, possibility of the hepatolenticular degeneration, that is the Wilson's disease. So the seroplasminin levels were normal. And then we also do the echocardiography. Ejection fraction of 32 is lower down, and when it means that now you have to do the electrocardiography as well. It was done because the patient has got, is in stress, respiratory distress, and the left ventricular diastolic volume was increased. Then there is a pumping problem, and there is generalized type of hypokinesia seen in the overall. Remember anything, and this is a sentence quoting to you, whether the patient is in the septicemia or viremia or fungemia or severe parasitemia, whatever it is, the heart is also involved, and it shows the hypokinesia, the activity, the pumping of the heart will be decreased in all these cases. So it's a part of the disease which you have seen, that is what is the underlying problem which is going on. On the morning of the second day, the random blood sugar was 80, the sodium was 128, is all lower down further. Urea was 69, and serum creatinine is also reading. Although it is again the prerenal type of azotemia still, but it is moving towards the renal compromisation because of the blood flow to the kidney is affected. Because you see the hypertension is 80/65. Hypertension is definitely affecting the patient. It means that whatever measures which we have done previously was not effective. The pulse was 118 per minute, is now tachycardia, severe, is compensatory. It means that the carditis has occurred. Myocarditis, that is called. It is a part of this disease. The urine output in 24 hours is 480 ml. It is oliguric. The patient becomes oliguric. And the Glasgow Coma scale now is lowered down much, from 12 to 9 now. The patient is in a worsening position in spite of your efforts. Differential diagnosis, after all this, all the work you have done, after investigations and after the previous differential diagnosis, and tapering it to like this, it may be the CLD end stage or decompensated chronic liver disease, hepatic encephalopathy, acute alcoholic hepatitis, possibly the patient, because he is executive type of a person, he is not executive type of a person, but he is a sanitary worker. Sanitary workers are mostly in our country are Christians, and they took the alcohol usually thrice or four times in a week, possibly of acute alcoholic hepatitis. The drugs-induced hepatitis, because he had been taking the drugs probably by some general practitioner has given, or a self-induced drug. It may be a toxic type of encephalopathy, which we are dealing now. And again, the same thing, that is the Wilson disease is the toxic encephalopathy, one of the, and it may be acute fulminant hepatitis. Remember that in young persons, always it is usually very rare also. Alpha 1 antitrypsin deficiency can cause the liver disease with emphysema. The young person, two diseases should be included always. One is what is called as the Wilson disease, and second one is the alpha 1 antitrypsin deficiency. So there are 5 differential diagnoses which we are in the mind. It means that I am the house officer, the second house officer is with me on the other bed, and third one is my group is 3 house officers. We are discussing this case with 3 of the house officers. And imagine that the postgraduate was also present. If he is present, or he was present, then the discussion will be open to him. He starts that what is your man, what is the possibility, what is one diagnosis you can quote that this is the one. All are relating with the liver. Remember, not other than the liver. It is the problem which is in the liver. Severity is much. It is acute type of problems the liver is facing. And the patient is deteriorating day by day. And the discussion is open for everybody. If it was the DSC, DSLD means that it is the decompensation, then the signs of the portal hypertension and others will be visible in this patient. There is no peripheral stigmata are seen, or the signs of the portal hypertension not seen. Hepatic encephalopathy means that the liver is actually diseased, whether acute or by chronic progressive disease, and it is leading to the hepatic encephalopathy. So it is a double, it may be possibility of the acute, it may be acute or chronic, or it may be a chronic type of in hepatitis. Acute alcohol hepatitis, if it occurs, that it will definitely involve the liver very badly, and it can cause the same thing which I said, that is the hepatic encephalopathy associated with it, yes, but it will not cause the other things which are seen in this patient. Means that the carditis, myocarditis, cardiac, decompensation, and he is hypoxic. The patient is in respiratory distress, is not seen in this case. So usually chances are lower down. Drug-induced hepatitis or toxic encephalopathy is because there are the history was present. Of the paracetamol, for example, is one drug which can cause it. And the heavy dose of the paracetamol has been taken for a suicide. The patient was not, why he has done suicide. There was no history, background of the suicide. Or any other drugs, hypnotics or tranquilizers and other things, or metallic type of poisons, no. Toxic type of encephalopathy means that other than this, toxins are releasing intrinsically from the body and affecting the brain, as which is called the toxic type of encephalopathy. Along with it, there are certain diseases in which case the virus is involving the brain, and it's called what is called the viral associated encephalopathy. But liver is actually involved here. I'm not discussing, but I'm discussing encephalopathy, toxic or viral induced encephalopathy. It is not possibility in this case. Very least possibility of drug-induced hepatitis. The fifth one is acute fulminant hepatitis, and that is called acute liver failure. This is the diagnosis in my mind when I was dealing this case. Acute fulminant hepatitis. That is the correct one. The final diagnosis is acute fulminant hepatitis. So we discuss each other and trying to justify with each other. Discuss among other house officer, RMO, CMO, PG for this final conclusion. If nobody is interested, then open current medical diagnosis and read this topic, acute fulminant hepatitis or acute liver failure, and make summary of this case, as this will help you in your post-graduation. When a diary is made, if you will read it out before going into the PG examination, it will 100% helpful in passing that examination. This is the correct way to study the case. So, up till now, some help is there, discussion, there is PBL, it is a problem-based case. So, 2 or 3 or 4 persons are involved. They are all reading the books or journals or Google searchers or etc. And they are making this diagnosis. And as acute fulminant hepatitis, and everybody is satisfied. The theoretical concept is in this slide. Actually, this acute liver failure is not a very, very common disease. It is a complex critical illness, first of all. It is not seen very, very commonly. And immune dysregulation, the pathogenesis of acute liver failure is described in this diagram. I don't want to discuss it because it's purely theoretical. I know that you can read it and make yourself more knowledgeable. Because clinically I have diagnosed it, and I have got the stigmata, I have got the markers of the acute fulminant hepatitis. The problem is that this patient has the high risk of developing the complications of the acute fulminant hepatitis. The most important complication is hepatic encephalopathy, the bleeding diathesis. Another problem which is this, along with this cerebral edema. Another problem is hepatopulmonary syndrome is associated. Another problem is hepatorenal syndrome may be associated. When you read it from the journal, it is the Journal of Hepatology. And it is written in the lower down for the month of 2021. It is written in the Journal of Hepatology. So this snapshot should be taken out. Snapshot of that and describing it. And if you read it from here or from the current medical diagnosis, Harrison textbooks of medicine, then you can understand well, which I have said is definitely I have given you a knowledge, not 100%. Maybe something is missing from my side. Now this is actually the thing that the open question, those who attended this tutorial which I have given, about 38 minutes have been gone. Okay, what was the clinical diagnosis? This is question number 1. Clinical diagnosis. What is the pathological diagnosis? Is there any lack of investigation? All investigation have been done. Something is missing. We quoted. What lines of therapy should be applied in this case? From the first day to the second day to the third day, how you can help? You should be all together in a one place, or 2 or 3 or 4% and discuss it, how you can manage it. In the presence of a supervisor if it is possible. If there is no supervisor, then one person become a supervisor and 3 are subordinates. Just imagine, and they discuss it out. How to manage it? Can this patient, because the patient is in a severe state, can be saved according to the recent advances? Again, it is written in the journal, it is written in the Harrison, it is written in the current medical. Apply it here. If it is indicated, if it is possibility. To save this patient at any cost, because the life is very important. And the quality of the life is very important. Rather than to make money and money and money, and our profession now becomes the health industry. It is not the what is called humanity services given for the humanity. It is not. It is not. It is the secondary, tertiary type of a, aim here. The first aim to earn money. Most of the hospitals make money as much as you can from this patient, because there are persons who are health carers of this person who is admitted, and they will definitely provide money from the other people of the family, and 10,000 rupees, 20,000 rupees, 40,000 rupees, 50,000 rupees, whatever it is. Because वो तो आप क्या आप they are what you said, they will accept it, because you have to save this patient. They are interested in the life of the patient, which are in your hands according to them. Although it is not in your hand, it is in the hands of the Almighty Allah. But for them, you are the Messiah for them. These are my questions. What was the clinical diagnosis? What is the pathological diagnosis? If there is any lack of investigation, what lines of therapy should be applied in this case? Can this patient can be saved? Can this patient saved according to the recent advances? Now this part was the last slide of this tutorial, and I have to answer, or you have to answer this. In the next session I will answer. I will try to answer it. But before I will answer, I will give you 24 hours to write it on the piece of the paper and match my knowledge, which I will deliver tomorrow probably. So please try to listen this video, watch this video very carefully, because it will give you knowledge, and knowledge is a power. If it is this, it means that you can be a very good clinician in the future. وَمَا عَلَيْنَا إِلَّا الْبَلَاغُ. We will meet again, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.